Good morning everyone. Today we'll discuss about renal tubular acidosis. So we see a lot of cases presenting with metabolic acidosis which are especially normal anion gap. So we'll always think about renal tubular acidosis. So we'll go into the RTA, how they present, what are the different types of renal tubular acidosis in the today's topic. So actually there are three kinds of renal tubular acidosis. Basically there is proximal RTA, distal RTA, and there is called type 4 RTA which is hyperkalemic. So first we'll go on a case-based scenario. 8-year-old boy presented with the complaints of poor growth and an evaluation was found to have normal anion gap metabolic acidosis and an evaluation has low phosphate and an urine examination found to have glycosuria and phosphaturia. So this is an 8-year-old boy. He has a stunted growth. So he's brought to the complaint of short stature and skeletal deformities and as an evaluation has normal anion gap metabolic acidosis. So then an evaluation has low phosphate also and has glycosuria and phosphaturia. So any patient coming with short stature, you need to assess what is the height, how much height standard deviation below it is, and also you need to check for the bone age, and what is the bone age, what is the height age and weight age and chronological age. So and on evaluation you need to check for any like is a proportional or disproportionate short stature is there, like proportionate goes mostly endocrine, like any thyroid disorder, any growth hormone deficiency is there, disproportionate any skeletal dysplasias are there. And then you also look for the other causes like any nutritional deficiency like malnutrition is there, any sometimes rickets can cause stunted growth also. So like that in this case there is a poor growth and also skeletal deformities are there. And on a routine evaluation you check for calcium, phosphorus and all. So here low phosphate is there and also an evaluation has normal anion gap metabolic acidosis. So coming into, we know the metabolic acidosis, there is high anion gap and normal anion gap. So we discussed about the AB chapter, what are the different causes of HAGMA and NAGMA. Here I am not going to revise all of them. I will go into the NAGMA directly. NAGMA we will directly look at the one of the most common cause of normal anion gap metabolic acidosis. One is RTA. Other can be GI causes also. How to differentiate between the GI causes and the renal cause? One is a urine anion gap you can do. Urine anion gap is positive. That means that is a renal loss. If it is not positive, it is extrarenal loss. So this is the basic understanding about NAGMA. NAGMA, you do urine anion gap. Urine anion gap is positive, that is suggestive of renal loss. Not positive, that is suggestive of extrarenal. That can be GA or anything, erythrosigmoidostomy, that can be many other causes. But urine anion gap positive suggestive of renal loss. So that is suggestive of renal tubular acidosis. Coming to the renal tubular acidosis, whether the proximal or distal is the second question. So most common are proximal or distal. Coming to the proximal and distal, proximal is where the most of the ions are absorbed, like phosphate, glucose, sodium. Almost all the ions in the kidney and nephron are absorbed in the proximal level except one. Magnesium is chiefly absorbed in the thick ascending loop of Henle. All other ions are mostly absorbed in the PCT except magnesium, which is absorbed in the thick ascending loop of Henle. So this patient has NAGMA. Maybe they did urine anion gap, that is suggestive of renal loss. Again in the proximal tubule there is loss of other ions along with the like acidosis, like along there is a bicarbonate loss, there is a bicarbonate malabsorption, there is protein malabsorption, there is phosphate, there is glucose malabsorption. So if there is a NAGMA which and urine anion gap is suggestive of renal tubular acidosis, and in the renal tubular acidosis where you find other ion loss also like phosphate loss, glucose loss or protein loss, bicarbonate loss, like these are all there, that is suggestive of proximal RTA, that is type 2 RTA. So this might be a case of type 2 RTA that can cause defect in the phosphate loss also. So that can be that can cause glycosuria also. So because most of the ions are absorbed in PCD, this might be a case of proximal RTA. So what are the things you see in the proximal RTA? Generally proximal RTA, when you check, there won't be any significant acidosis like you see in the case of distal RTA, because if bicarbonate is being lost also, it is able to compensate the distal part of the nephron. So that is why you don't find significant acidosis like in the distal RTA, where bicarbonate is around 15 to 18 in the case of proximal, 15, 14 in the case of proximal RTA, where you find 10s and 11s of bicarbonate in the distal RTA. And next thing is you will find other ions loss like phosphate loss, glucose loss, protein loss. These all will be formed in the case of proximal RTA. And one more thing is stones. Stones are very rare in the case of proximal RTA. In the distal RTA you will find stones very common in the case of distal RTA. So why is it? I'll tell in the distal RTA part. But stones are very common in the distal RTA, where proximal RTA stones are very uncommon, except 2 or 3 causes, like in the case of cystinosis you might find stones, and topiramate you might find stones. These are the 2 causes where you can find stones in the case of proximal. There are 2 exceptions. So this might be a case of proximal RTA. How do you treat? We will discuss about the next in the coming chapter, coming slides. So this is a normal ion gap. Generally you will find in the case, how do you tell if it is a metabolic acidosis is not due to the CKD or AK? In generally CKD AK you will find creatinine will be elevated. Otherwise metabolic acidosis accompanied by norm or hypochloremia. But in the case of renal tubular acidosis, it will be able to compensate this form with hyperchloremia. Because in the case of CKD or AK, it is hagma. It is not nagma. Hagma, where you will find bicarbonate will be low and also chloride also will be low or normal. In the case of renal tubular acidosis, with the loss of bicarbonate to maintain the anion gap, hyperchloremia will be there. So impaired urinary excretion, normal GFR is seen. So proximality, it can be defect in the whether it is the H plus ATPase channel or sodium hydrogen exchange 3 or carbonic anhydrase 2 and also bicarbonate exchanger, anywhere defect can be seen. So primarily inherited causes are there, SLCA4, C4A4, SLC9A3 is there. Drugs mostly carbonic anhydrase inhibitors which are involved in the bicarbonate absorption like acetazolamide, topiramate, sulfonamides and carbonic anhydrase 2 inhibitors that can be osteopetrosis, they can all cause proximality. Then cystinosis. Cystinosis is one of the most common cause of proximality. Cystinosis you will find Wilson's disease, tyrosinemia, other metabolic disease like this, galactosemia, pyruvate carboxylase, these all can cause. But cystinosis is one of the very common cause of proximality. And even the multiple myeloma and monoclonal gammopathies also you will find proximality. Even vitamin D deficiency or dependency can also cause proximality. And drugs like iphosphate, outdated tetracycline, lead, amphotericin B, they can cause. Sjogren's predominantly cause distality but can cause proximality also. PNH can cause RTA. These are all called nephrotic syndrome, amyloidosis can cause proximality. So this is the mechanism. Generally what happens is, what is the problem in the case of proximality is the absorption of the bicarbonate is the problem. So generally bicarbonate is filtered through the proximal tubule which beyond the receptor capacity. It was not able to absorb at the proximal level, proximal tubule level, so it is absorbed. So increased bicarbonate delivery to the loop of Henle and distal tubule beyond the receptor capacity. So there will be bicarbonaturia. So what will happen because of the bicarbonaturia? There will be decreased bicarbonate level in the serum. So because of the decrease in the serum bicarbonate, filtered load also will decrease. So the amount of being filtered in the glomerulus also will decrease. So this will happen is, what will happen, it will create a new set point. So with the loss of bicarbonaturia, the distal tubule will try to compensate for some point. So it will make a new steady point of bicarbonate around 14 or 15. It will make new steady point. That is a new steady point for bicarbonate. So it will filter less and it will able to compensate at distal level. So that it will create a new set point in the serum. So loop of Henle are able to reabsorb at a certain bit. So it will create a bicarbonaturia and new serum bicarbonate steady state is reached. So that it also decrease the filtration and also maximally reabsorbs at the distal level also. So and increase RAS activation, distal sodium is also increased. This hyperaldosteronism. So what causes? Because of the decrease in the bicarbonaturia, it increases the sodium load also in the distal level. So in order to cause a sodium reabsorption, what will happen? Because the distal area of sodium is also both bicarbonate and sodium are increased at the distal level. What will happen? It will stimulate the RAS pathway. RAS pathway will stimulate the aldosterone. Aldosterone will stimulate the ENaC channel. So sodium will be absorbed, potassium will be excreted. So it will create the hypokalemia. So this is what happens. This is the cause of hypokalemia in the case of proximality. So what will happen? Because of the distal sodium bicarbonate delivery, it will stimulate the RAS and hyperaldosterone pathway, which will stimulate the sodium reabsorption and increase the potassium excretion. That is causing hypokalemia. So this is the mechanism. So associated hypophosphaturia, uricosuriia, amino aciduria. So these are all seen in the case of the proximality. So hypophosphatemia can cause bone demineralization, osteopenia and reduced bone growth in the children. This is the case we have seen. So treatment. What is the treatment? We have to increase the bicarbonate concentration as close to normal. So you need not correct it to the totally upper limit of normal. What is the problem with this is, if you go to the upper limit of normal, let's say you are making bicarbonate 24 or 22. So with increasing serum bicarbonate, what will happen? It cause the filtering load of bicarbonate also will increase. So if the filtering load of bicarbonate increases, what will happen? A proximal tubule is anyways not working. So it will filter. So it will create the distal delivery increases. So with increasing bicarbonate, more filtration will occur, more distal delivery occurs. More distal delivery, more RAS activation, more aldosterone activation, it will worsen the hypokalemia. So that is why you should always keep the target of bicarbonate to the lower limit of normal, like just a normal 18 or something. So that is the thing with proximality. If you give more bicarbonate, it will worsen the hypokalemia because of the increased distal delivery of sodium bicarbonate, which will in turn causes the hypokalemia because of the stimulation of hyperaldosteronism. So increased distal sodium in combination with increased plasmodulation will worsen the hypokalemia. That's why you need to keep this in mind when you are correcting the proximal arterial bicarbonate. So generally we keep in children, because of the stunted growth, you go for higher dose like 5 to 15 milliosmolars per kg. That is bicarbonate dose in case, because in them significant bone defects are there. So hypophosphatemia is there, and it can cause bone demineralization. That is why in proximal RTA in the case of children are treated aggressively with the higher dose like 5 to 15 milliosmolars per kg. So in adults, you need not correct it very aggressively because most of the bones are formed, no significant stunting will occur. So may administer alkali in the case of adults to maintain around 18. Just the lower limit is enough because more you give, more hypokalemia will worsen. That is why in 18 millimoles is enough to prevent the acidosis. Just to prevent the acidosis, just to maintain the lower limit of normal is enough in the case of adults. But in the case of children, because bone demineralization, bone defects are there, you need to correct the full dose, correct, like 5 to 15 millimoles per kg is there. So what is the reason you are correcting at the lower limit of normal? Because if you give excess bicarb, more filtration, more distal delivery, more RAS activation, more sodium reabsorption, worsening of hypokalemia. That is why you just maintain at lower limit of normal of bicarbonate. So generally how do we give? Generally you can give the potassium citrate. So generally potassium citrate, what do you give? Generally we give soda bicarb tablets. In the case of CKD, we give soda bicarb. Why we are giving soda bicarb in CKD to correct acidosis? Why we are giving potassium citrate in the case of distal and proximal RTA is because in the case of CKD and AK, what will happen? Whatever metabolic acidosis is purely due to bicarbonate decrease, due to the bicarbonate. So in the case of this, there is hypokalemia also. So we need to address both hypokalemia and address the bicarbonate also. So what will happen in this potassium citrate? Potassium will correct the hypokalemia. Citrate converts into bicarbonate. So that is why potassium citrate is preferred to correct the RTA related metabolic acidosis because it corrects the both hypokalemia, which is causing the proximal distal RTA related hypokalemia is being corrected, and also acidosis is being corrected because citrate is converted into bicarbonate in the body. So that is why you prefer potassium citrate in the case of proximal and distal RTA. So the dosage is 55 to you can check the converter. I think around 5 ml contains 10 milliequivalents of bicarbonate something, potassium citrate. So you can check for the conversion and use accordingly based on the how many millimoles you require based on the dosage. Just to maintain the 18 millimoles per liter of bicarbonate. So case 2. A 50-year-old female presented with renal stones and bone pains and evaluation was found to have nagma. So this is a 50-year-old female, elderly female. She has renal stones and and bone pains are present and an evaluation was found to have nagma. So anyway, any patient that has normal anion gap metabolic acidosis, you find them have urine anion gap which is positive suggestive of renal loss. Then you get look at the bicarbonate. Bicarbonate is around. Distal RTA will have significant acidosis. Like it depends on the duration of disease. So initial stages of a distal RTA will have bicarb of 18 or 19. Mild acidosis will be there. With the ongoing duration of the disease, RTA, distal RTA metabolic acidosis worsens. So with 10 years disease, bicarb might be 8 or 9. But only 1 year disease, it might be 18 or 16 or something. So with progressing disease, RTA will worsen in the case of distal RTA. So this is there, and distal RTA will have bicarbonaturia, and one they can present with hypokalemic paralysis sometimes because of the hypokalemia, hypokalemic period, recurring episodes are there, hypokalemic periodic paralysis the presentation. They can present with renal stones. What is the cause of renal stones in the case of distal RTA is because of the metabolic acidosis that is there in the body, significant metabolic acidosis, it causes resorption of bone. So resorption of bones will be there, hypercalcemia will be there in the body. So calcium will be excreted more in the kidney to prevent the hypercalcemia in the serum. So this calcium will precipitate with the citrate and whatever calcium citrate that can cause calcium stones in the stones. So because of the significant resorption of the bone, because of the metabolic acidosis, this cause calciuria. Calciuria will precipitate and cause calcium stones in the urine. So that is the cause of renal stones in the case of distal RTA, and they can have hypokalemic periodic paralysis. They're generally associated with Sjogren's. They can have rheumatoid arthritis where they have dryness of mouth or joint pains will be there. So generally Sjogren's are common in this female. You need to evaluate for Sjogren's. Sjogren's is one of the most common cause of distal RTA. So they'll have renal stones, bone pains because of the resorption of the bones, and nagma will be there. So this is there. So one more difference between the proximal and distal RTA is you can challenge, like generally urine pH will be more than 5.3 in the case of distal RTA. So no amount of acidification you can you do. There is a you can't acidify the urine in the case of distal RTA. Urine pH will always be more than 5.3 in the case of distal RTA. Whereas in the case of proximal RTA, sometimes it depends on the bicarbonate resorption capacity. Sometimes urine pH might go less than 5.3 in the case of proximal RTA, whereas in the distal RTA you might not be able to acidify the urine despite of your effort. Like let's say if pH is 7.1 in the serum, generally urine should be acidic in order to able to excrete the acid in the body. But in the case of distal RTA, they are not able to acidify the urine. So that despite of metabolic acidosis in the body, still urine pH is more than 5.3. Even if you do ammonium loading test also, urine pH will be more than 5.3 in the case of distal RTA. That is a classical feature of distal RTA, where urine pH despite of the metabolic acidosis in the body or ammonium chloride challenge test or acid challenge test you do, despite of that urine pH will be more than 5.3 in the case of distal RTA, but sometimes in the case of proximal RTA it might come down to less than 5.3. So that is one differentiating point between the proximal and distal RTA. So this is the distal artery. Because of the this is due to the acidification defect in the distal tubule. So whereas the proximal artery is due to the absorption of the bicarbonate defect, where the distal artery is due to the acidification defect, that is alpha intercalated cells. So this is inability to, you can't bring down the urine pH less than 5.3 in the case of distal artery. So this is a defect in the H plus excretion in the collecting duct, and defect to ammonia NH4 plus ion formation in the case of distal artery. So this is the defect H plus K2 plus ATP anion exchanger 1 and carbonic anhydrous 2. These all can be defect in the case of distal artery. So these are the various causes like that can be due to ATP 6V1B1 or ATP6V0A4 defect can be there. Most common causes of autoimmune causes like Sjogren's syndrome, cryoglobulinemia, HIV can cause associated Sjogren's like primary biliary cirrhosis can be there, ulcerative colitis can be there, polyarthritis nodosa can be there. So chronic active hepatitis can be there. Hypercalciuria and nephrocalcinosis commonly seen because of the resorption of the bone, that can be due to the primary hyperthyroidism, vitamin D intoxication, which can cause hypercalcium. They can also cause distal artery. Wilson's disease generally causes proximal artery but can cause distal artery also. Drugs like amphotericin B, toluene can cause, high phosphate lithium can cause. These all can cause distal artery. And Balkan's nephropathy, kidney transplantation, leprosy, and there are hereditary like sickle cell, Marfan's, medullary cystic kidney. These all can cause distal artery. So these are due to the defective acid formation. H plus ion cannot be secreted, that can lead to the defective formation of NH4 plus, and so there is no acidification of the urine. That can cause the stone formation. So this is they can present with proximal muscle weakness. They can cause polydipsia and polyuria because they can cause nephrogenic DI also, and sometimes milderly renal calculi can be presentation. So distal artery generally, despite immunication, generally bicarbonate can be as low as 10. And with the duration of disease it depends. Early disease can have bicarb of 18. With the ongoing disease it can go as low as 10 millimoles per liter. So hypokalemia can be presentation. Nephrogenic DI also can be presentation in the case of distal artery. So management, like unlike in the case of proximal artery where you go for lower targets, here you go for the higher targets. Like bicarbonate should be maintained more than 22 millimoles per liter, because in proximal artery if you give more bicarb, hypokalemia will worsen because the distal delivery increases. In this case, there is distally their loss is there, so you should maintain the bicarbonate to more than 22 millimoles per liter to prevent the bone health, because there is significant osteoporosis, the bone resorption is poor, so that you need to maintain the bicarbonate more than 22 millimoles per liter. So generally you need require around 500 milligrams to soda bicarb 400, like you can give potassium citrate also. Potassium citrate will correct both hypokalemia and metabolic acidosis, whereas you can give soda bicarb tablets also if there is only metabolic acidosis. So that is there in the case of 500 milligrams to 1 gram twice daily. That is around 1 to 2 millimoles per kg per day is the dose you require in the case of distal artery. Whereas in the proximal artery for children it is very high, 5 to 50 millimoles per kg per day. But adults you only maintain till 18 millimoles per day, whatever dose is required. In the case of distal artery, 1 to 2 millimoles per kg per day. If hypokalemia is there, you can give potassium citrate. If there is no hypokalemia, you can give soda bicarb directly around 500 to 1 gram thrice daily. So primary for treatment, you need to prevent the osteopenia and reduce the stone formation and reduce the urinary potassium loss. You need to give bicarb. So potassium citrate can be given if there is a hypokalemia and to prevent the renal stones. Case 4. A 50-year-old known case of diabetic present with hyperkalemia after initiating NSAIDs and is associated with acidosis. So this is one case, and 60-year-old male on DVT prophylaxis developed hyperkalemia and metabolic acidosis. So till now we discussed about the proximal and distal artery where hypokalemia is common, and in proximal artery there is other ion loss, and you can bring down the urine pH less than 5.3 but in the case of distal artery there is no other ion loss. There is hypokalemia, renal stones and diabetes insipidus can be there, but there is no other ion loss. But despite of the maximum acid loading also, you cannot bring down the urine pH less than 5.3. Urine pH will still be more than 5.3 in the case of distal artery. These both are associated with hypokalemia. But here we are discussing about the hyperkalemia, where after in a case, especially in the case of diabetes mellitus, after initiating NSAID, the patient developed hyperkalemia and metabolic acidosis. So this might be a case of type 4 RTA, where metabolic acidosis hyperkalemia is there. So this is also second case where 60-year-old female on DVT prophylaxis, you used heparin for that case. So heparin also can cause hyperkalemia and metabolic acidosis because of the defect in the aldosterone synthesis. So heparin inhibit the aldosterone synthesis, that can cause type 4 RTA. So type 4 RTA can be due to the problem in the nephron dysfunction, that can be due to the both the defective secretion of H plus and AK plus, that can be due to the aldosterone synthesis defect or action defect, or due to the channels defect where they can cause defective excretion of both acid and potassium into the urine. So they will have hyperkalemia, acidosis. So that can be due to aldosterone synthesis defect or aldosterone action defect or due to the channel defect. Okay. So there are various causes of this. So impaired sodium resorption of the principal salt. So decreased driving force of H plus secretion and potassium excretion will be there. So there will be hyperkalemia and acidosis. So hyperkalemia, type 4 RTA is more common. Type 4 RTA is more common than type 1 RTA, particularly in the adults. So these are the common. So that can be due to the mineralocorticoid deficiency, like in the younger onset that can be Addison's disease, or bilateral adrenalectomy can be there, or congenital enzymatic defect like 21 alpha hydroxylase or 3 beta hydroxylase, or isolated aldosterone deficiency. That can be heparin. Heparin is a common cause, one of the most common causes we see in the ICU, where hyperkalemia and metabolic acidosis can be seen in the DVT or whatever it is. So other things like angiotensin inhibitions like AC or ARB inhibitors can cause hyperkalemia because of the type 4 RTA. So then distal tubular nephrosclerosis, NSAIDs can cause, obstructive uropathy can cause, or all mineralocorticoid resistance can like that can be due to the autosomal dominant primary hyperaldosteronism type 1, where the resistance due to the aldosterone is seen. So type 1 and type 2 are the drugs like emeralide, triamtrin, trimethoprim, cyclosporin, tacrolimus. They all can cause hyperkalemic RTA. Spironolactone, eplerenone, they all can cause defective aldosterone action and can cause type 4 RTA. Other like lupus nephritis, obstructive neuropathy, sickle cell, they all can cause type 4 RTA. So these are the mostly seen in the elderly people and can have bicarbonate is usually 18 to 22, but potassium is 5.5 to 6.5. So with moderate reduction in GFR will be slightly reduced. Generally, usually not significantly reduced, but mildly reduced GFR will be there. If significantly reduced, you will have metabolic acidosis secondary to CKD only. But if type 4 RTA, mildly reduced GFR will be there, associated hyperkalemia will be there. Like after initiating some NSAIDs or something, you will have hyperkalemia with mild acidosis pattern will be there. That is a case of type 4 RTA. So management, discontinue all drugs, like any drugs that can cause type 4 like heparin or NSAIDs are there, you can decrease you can discontinue the drugs, and if there is any underlying condition that can cause type 4 RTA like diabetes, or that should be treated, and restrict the potassium, and also if you required you can give sodium bicarbonate supplementation also. So this is the case in the case of RTA management. Any volume depletion is there, you can treat. If there is any CKD or something is there, you can administer the like CKD related hypertension or volume or ladies, you can administer the thiazide diuretics also. If significant hyperkalemia is there, you can give potassium binders also is there. So if there is aldosterone deficiency secondary to some enzyme deficiency or whatever synthesis defect is there, you can give fludrocortisone also in these patients. So this is the approach. Normal and gap, check the creatinine and potassium. If high creatinine normal to high potassium is there, go for AK or CKD or type 4 RTA is there. If normal creatinine is there, you check for urea and gap and ammonium excretion. If it is positive, it is suggestive of RTA. If it is negative, it is suggestive of GI loss. So NAGMA with normal creatinine and low to normal potassium, check urine ion gap. If it is positive, suggestive of RTA. If it is negative, it is suggestive of GI loss. If already high creatinine is there, high to normal potassium is there, only think about AK or CKD or type 4 RTA. In the AK CKD, significantly decreased GFR is there, but in the case of type 4 RTA, mildly reduced GFR with hyperkalemia with mild acidosis will be there. So in the type 4 RTA, you check for aldosterone synthesis defect, any action defect, or any drugs that can cause, or any channel defects in the distal tubular level, you can look for that. And again in the RTA level, you do the urine pH and urine bicarbonate. Generally in the case of distal RTA, urine pH will be more than 5.5 and bicarbonate excretion will be less than 5%. So despite of the maximum acid challenges, urine pH will still be more than 5.5 and bicarbonate absorption will be less than, fraction excretion of bicarbonate will be less than 5% in the case of distal RTA. Confirmed by acid loading test, that is ammonium chloride test you can use. You will have hypercalciuria, nephrocalcinosis, hypocitruria, generally associated with autoimmune disorders. In the case of proximal RTA, you will have urine pH less than 5.5. That urine pH can be estified in the case of proximal RTA, and bicarbonate excretion will be more than 15%. And they will have associated phosphaturia, glycosuria, and low molecular proteinuria. Generally associated genetic disorders like cystinosis or Wilson's disease or some Fanconi syndrome will be there in the case of proximal RTA. So these are the differences in proximal RTA. Serum bicarbonate will be 15 to 18 in the case of proximal RTA, whereas less than 10 to 12 in the case of distal RTA. It depends on the duration of disease also. Low phosphorus, generally low to normal, potassium will be low, and generally distal RTA will also be low. Glucosuria will be there, ammoniaciduria will be there, phosphaturia will be there in the case of proximal RTA. But calciuria will also be there in the case of proximal RTA, but does not generally cause stones in the case of proximal RTA. Whereas in the case of distal RTA, stones will be formed because of the citrate also will be lost. So citrate will prevent the stone formation in the case of generally. So this also urine citrate will be normal in the case of proximality. It is decreased in the case of distality. This is one of the cause for the distality. That is why potassium citrate will prevent the stone formation also. So distal RTS, citrate secretion also decrease in the case of distality. That is one more risk factor for the stone formation. So urine pH will be less than 6 but more than 5.5 is what we take. And bicarbonate more required, generally more than 10 milliequivalent per kg. But we don't give that so much in the case of adults because it can cause hypokalemia, more worsens the hypokalemia. But in the case of this case, 1 to 3 milliequivalents per kg is enough in the case of distality. Bone disease is rare, common because osteoporosis, because of significant metabolic acidosis, osteoporosis is common in the case of distality. Nephrolithiasis is common in the case of distality, or not common in the case of proximality. So which requires more bicarbonate is proximality requires more bicarbonate. As you can see in children it requires almost 5 to 50 millimoles per kg per day is required in the case of children. In children you go for full correction and you need to correct the proximality, but in adults you only need to maintain bicarbonate 18 or something. In distality you need to correct the bicarbonate to 22, higher limit of normal, whereas proximality you need to correct the lower limit of normal. So that is about the RTS. Thank you.